Hi, we're fortunate today to be speaking with Dr. Ken Sassower, a clinician and researcher from Harvard Medical School and the Massachusetts General Hospital, who has many years of expertise in pediatric neurology, child and adult epilepsy, and sleep medicine. And we're here today to talk about sleep issues in persons with autism spectrum disorder. I'm Marvin Natowicz. I'm a professor at the Cleveland Clinic Lerner College of Medicine, and I'm staff member at the Cleveland Clinic in medical genetics and pathology. And the learning objectives for today are first to discuss the fundamentals of sleep biology. Second, to discuss different types of sleep disturbances that occur in persons with autism spectrum disorder, including disturbances that can be secondary to behavioral or psychiatric concerns, disturbances of sleep that can occur secondary to medical issues, and disturbances that can occur secondary to neurological issues. And in so doing, reinforce for clinicians when to suspect an underlying behavioral basis or a medical basis or a neurological basis for their patient's sleep dysfunction. And finally, the last learning objective of today's webinar is to provide information for clinicians when it may be appropriate to refer a patient for evaluation by a specialist in sleep medicine. To begin with, Dr. Sassower, and thank you very much for being part of this, can you comment for us why, in fact, is sleep even important?
Well, Marvin, there's a lot of theories about why sleep might be important, and I think about 20 years ago I attended a symposium, an international symposium on sleep, and we were trying to find out what was the purpose of sleep, what are the benefits of sleep, and it turns out this is probably not a solitary or a unitary reason, but that there are multiple reasons. People have suggested, even from the time of, from an evolutionary point of view, that being inactive during a period of the nighttime would be helpful to avoid being preyed on, predatory animals, this sort of thing, and not being active would also be helpful in terms of just preservation of the species. Other folks have suggested that there's some form of energy conservation that occurs at sleep. We say, for example, humans probably expend about 10% less energy while they're sleeping, and then it may have vital functions as well to do that. There's a restorative nature. There are proteins that are synthesized in sleep, hormones that are synthesized in sleep, growth hormone, for example. And there are also things like, for example, muscle growth, tissue repair, this sort of thing is also very important during sleep. And then there's the whole notion in terms of, from a cognition point of view, the benefits of learning and memory with regards to sleep. We know, for example, that sleep is very important in terms of learning and enhancing memory function. And so there's that aspect as well. And then there's this whole notion of neuroplasticity, where things change over the course of the human life cycle. So, for example, newborn infants may have lots of REM sleep, or what we refer to as slow wave sleep, which is very restorative, deep sleep. And over the course of the human life cycle, it sort of diminishes over time, and it becomes less apparent as we become elderly. So there's lots of different putative theories as to why sleep is beneficial, and those are some.
Mm-hmm. It would seem that one could also infer about the importance of sleep by from situations where sleep is impaired. You could infer perhaps importances to a person or to the family or to society at large even.
That's right.
what can happen if someone is sleep deprived to a person or to family? What are some of the consequences, and how can you gauge the importance of sleep looked at from that angle?
Well, I think in terms of the individual, sleep deprivation, and I think it's different in terms of the adult paradigm versus pediatrics. If you sleep deprive an adult, by and large, the most prominent clinical manifestation will be sleepiness. So it makes sense. We are sort of, and similar to a hunger model. If we don't eat food, we're hungry as a result of that. But for children, there is that aspect of sleepiness, but also children are particularly prone to having neurobehavioral alterations in concentration and attention, disorders in executive functioning as a result of sleep deprivation. And it's not clear exactly why that is. Some individuals think that children are more vulnerable to dysfunction in the prefrontal cortex. And as a result, they may have more executive dysfunction issues, attentional issues, difficulties in concentration. So it may be you're taking a population of children who may be more vulnerable to attention deficit disorder, for example, and by virtue of relative sleep deprivation, exacerbating that tendency. And in terms of perhaps the larger scope, in terms of how does that impact, for example, families. You have children, for example, the children on the spectrum. You have children who have difficulties who are getting to sleep or staying asleep, and they are, they may be up in the middle of the night, some of these children, and if the children are awake, the parents are awake. And that can lead to a whole host of issues. You have sleep-deprived children, you have sleep-deprived parents, and that has impact on daily work functioning. Parents have to go to work and they don't function optimally. The children are impacted by virtue of the fact that they're sleep-deprived. And another important issue is that these children, by and large, children on the spectrum, many of them at least, are either nonverbal or preverbal. And it's that difficulty in terms of expressing the fact that they're sleepy or tired sort of has manifestations that are far-reaching. And it may result in irritability during the daytime, not being able to pay attention or to either the parents or at schools, not being able to focus, not being able to, it's also felt that sleep deprivation may worsen autistic behaviors, may exacerbate repetitive behaviors that may already exist in the autistic subpopulation. And then in terms of a society as a whole, there are lots of issues. We can look in terms of the whole notion. It's been thought that, for example, driving an automobile, singular motor vehicle accidents, in the context of being sleep deprived, is thought to be as much a public health issue as driving while impaired on alcohol or other drugs. And so it's a huge issue there. If you take very major cataclysmic events that have occurred in our recent history, the 3 Mile Island accident, the Exxon Valdez oil spill, were all thought to be related to sleep deprivation in terms of the operators. And so there are sort of lots of sort of societal issues. And then actually the very notion, what I call the rebirth of sleep apnea. We've known about sleep disorder breathing for years and years, from the time of the Pickwickian papers and Charles Dickens, excuse me. But they are, it turns out in the early 90s, there was a seminal work in the New England Journal of Medicine, which was looking at why truck drivers who were driving overnight shift were getting into trucking accidents. And it was actually looking in that public health venue, trying to see why these accidents were occurring, that they discovered a lot of these individuals were sleep deprived, and they were sleep deprived often due to sleep apnea. And that refocused our efforts on trying to diagnose and manage sleep disorder breathing.
Could you provide some basic background in terms of the neural substrates of sleeping and a little bit of background in terms of the key compounds that operate within those neural substrates that make us function normally with respect to sleep or dysfunction when there is dysfunction?
Yeah, absolutely. I think that if we take, for example, if we like to sort of look at the brain and brainstem from a top-down vantage point, you have these cortical-thalamic and thalamocortical pathways. We can sort of see evidence of thalamocortical integrity by looking at what we refer to as sleep spindles on a routine EEG. And that's helpful to assess that. That is a classic feature of routine sleep, and it always exists. And when you see examples of sleep spindles, which look like sort of intermittent coma-like projections on a EEG screen, it's verifiable and documented proof that a person is in what we refer to as stage 2 sleep. And so as we go further down, we actually look and see, for example, below the cortex, we're looking at the area of the hypothalamus. The hypothalamus is a very rich structure with regards to sleep-wake issues. And for example, there are lots of, if you look at the sort of lateral aspect of the hypothalamus, we have a neurochemical known as orexin. Orexin is a wake-promoting neurochemical, but it also works as almost, if you will, like a traffic cop in terms of regulating other wake-promoting neurochemicals. For example, the norepinephrine from the locus ceruleus, the serotonin from the dorsal raphe nucleus. So it all, dopamine from the periaqueductal gray. There is lots of, it almost as a, if you will, almost a supervisory component in regulating wake-promoting neurotransmission. And then, if you look also in, not far from that area are some of the more sleep-promoting areas. The ventrolateral preoptic area is thought to be a site that's particularly important with regards to enhancement of sleep. And so there's often a rich interplay between a neurotransmission that is wake-promoting versus neural transmission that is sleep-promoting. And sometimes we sort of see that rich interplay occur throughout the course of the day and night. And then to make matters either more easy or more complicated depending on the situation, they have a rich interplay between various stages of sleep. Like, for example, we have non-REM and REM sleep. REM sleep is thought to be predominantly cholinergically based. And we have sort of that interplay between REM sleep versus non-REM sleep, which are, those are more monoaminergic amines, where you're, so in addition to having the various interreactions, there we have what we refer to as REM on and REM off neurons, and that will decide whether a patient is in how deep a sleep they are in, and the various stages of sleep.
So Ken, you've mentioned just now REM sleep, you've mentioned a moment ago stage 2 sleep. Can you provide us an overview of different phases or stages of sleep, how they're evaluated, and to the best of our ability in 2014, what their functions are?
Absolutely. It's so at the very beginning, we have wakefulness, a state of wakefulness. And initially, I mean, centuries ago, it was thought that that sleep occurs when we're no longer awake. It was sort of that kind of, we're either awake or asleep, and that was all we knew about it. Now we know that there are various stages of sleep. So, for example, there is, once we take the wakeful, for example, even in looking at EEG, for example, we see very cardinal hallmark features on an awake EEG that are indisputable. We see evidence of a posterior dominant rhythm, which is a very sinusoidal waveform that's particularly evident over the posterior regions of the brain and are enhanced in a state of resting wakefulness. So, and how does that apply clinically? When folks are coming into an EEG lab, we just tell them to sort of close their eyes and relax. And we're careful that they don't fall asleep, but that they should just be in a state of resting wakefulness. And if that occurs, invariably virtually every individual will demonstrate this very sinusoidal waveform over the posterior region. We call it a posterior dominant rhythm. And then what happens is over time, when the eyes close and we get a little bit more drowsy, if you will, we get the first stage of sleep, which is truly drowsiness. And we take that posterior rhythm, and what happens is it becomes fragmented. It's no longer that very crisp, clear sinusoidal waveform, and it becomes almost like a rubber band that's slightly extended. And all of a sudden, the background becomes slow. And in that stage of sleep is almost what we refer to as very light sleep. Individuals can speak to you, you can understand what they're saying, and by and large catch most of what is occurring. Like, for example, if you're in a lecture and you get a little drowsy, you would still be able to capture most of what's being said. Over a period of time, you get into a deeper sleep pattern, which is stage 2 sleep, which is really enhanced by the presence of those sleep spindles I was referring to earlier. When you see that, it's a deeper sleep, but not all that different, all that deeper sleep. So what happens at that time is that you may be less apt to understand, for example, a lecturer or a friend speaking to you on the phone. You may be dipping in and out of conversation and may not understand or miss chunks of the conversation. And then you may wake up and get part of it and then go back to sleep, this sort of thing. And then you have deeper sleep. And the deepest form or one of the deepest forms of sleep is stage 3 sleep. It's non-REM, so it's not REM sleep quite yet. But it's
and
deep.
REM stands for?
I'm sorry, it's rapid eye movement sleep. And so the 2 deepest stages of sleep are stage 3, non-REM sleep, as well as stage REM sleep. And so in non-REM stage 3 sleep, it's thought to be very, it's thought to give an enhanced and restorative sleep. And there are a lot of vital functions that occur out of stage 3 sleep. For example, growth hormone, and it's thought to be intimately linked to stage 3 sleep. So that if individuals who are not getting a lot of stage 3 sleep may have impact on their growth hormone production. And if individuals get a more consolidated stage 3 sleep, they may have more improved or enhanced growth hormone production. And then you have, it's also particularly important in terms of children. Children who are in stage 3 sleep, it's thought to be a heightened threshold for arousal. So we have clinically we think about children, for example, who are in the depth of winter. They're in the car, parents are driving them around, and they're asleep, and it could be a winter's night, it could be freezing, it could be snowing. You put the child on your shoulder, you bring the child into their bedroom and put them down on the bed. They never once wake up, and they have no recall of that activity, and they really are in this extremely deep sleep. And when there are alterations in that stage 3 sleep, sometimes we see, for example, we hear about conditions like sleepwalking or confusional arousals or night terrors. They all occur out of that particular stage 3 sleep. And then REM sleep is another deep sleep state. We often refer to it as paradoxical sleep. It's paradoxical in the sense that it is deep sleep, but it is prone to disruptions, either internally or externally. So for example, if I have sleep apnea and I stop breathing, I might more readily stop breathing during REM sleep. And it will awaken me out of REM sleep. I may remember a dream because I was transiently in dream sleep, or I may not, but will often wake up out of REM sleep. So REM sleep is particularly a time of both deep sleep and internal and external disruptions. But so the whole composite of sleep is really going from light, drowsy sleep to stage 2 sleep, and then to the really deep stage 3 sleep, and the very deep stage REM sleep.
And do these stages have any pattern to them? Do they repeat?
These sleep cycles usually occur roughly around 90 minutes, every 90 to 120 minutes throughout the course of the night. So as a result, we often, if we don't have significant sleep disorders, we can have about 4 cycles over the course of a night. And it is in younger children, the sleep cycle is less. It's roughly around 50 to 60 minutes in a newborn. So they're shorter sleep cycles, but they also recur over the course of the night. And so there is a sort of a cycle to that. The clinical import sometimes of that is if I have a patient who says, you know, doc, I'm waking up every 2 hours on the hour. It's with that kind of rhythmicity and that kind of cyclicity, it usually suggests that there's maybe a REM process that's going on that's disturbed, such as, for example, sleep apnea. So if I hear somebody's waking up every 2 hours in the course of the nighttime, it makes me wonder about a REM-related process that's causing it. If you take a non-sleep deprived adult, they usually have a cycle that's lasting somewhere between 90 to 120 minutes in duration and recurs throughout the night.
Of all of the phases?
All the different phases of sleep, absolutely. And will recur over the course of the night, maybe 4 times or so, if you will. And then young children, particularly newborn infants, have very shorter sleep cycles, about 50 to 60 minutes duration, but they also recur and they cycle in all the different stages of sleep.
And are there any significant differences in the amount of any of the stages of sleep with respect to age? Do you see differences in the pattern of the sleep as one goes from, say, being a 1-year-old to a 10-year-old to a 30-year-old to an 80-year-old?
Yes, you do. And it turns out that, for example, if you take a newborn, their sleep, they roughly sleep around 16 to 18 hours a day, of which up to 10 hours of that could be in terms of nap sleep. And what happens over the course of time is that from the time you're roughly around 18 years of age to the time you're in your upper 60s, low 70s, you virtually have no more REM sleep. There are differences in terms of percentages of sleep across the human life cycle. Newborns, for example, roughly sleep about 16 to 18 hours throughout the course of the day and night. And approximately half of their sleep is in what we refer to as a precursor of REM sleep or active sleep. And that changes over time. And what happens is from the time you're roughly about 18 years of age to the time you're in your high 60s, low 70s, REM sleep occupies approximately 20% of your night's sleep.
So it's much less.
And much less, but it's pretty constant. But then but in the elderly, it becomes a problem in terms of sleeping because they lack REM sleep. For individuals in their early 70s typically lack REM sleep.
And even though we're going to get into this in more detail later on, would it be the case that there are some sleep disorders in which you have a disturbance of the normal patterning of the sleep cycle?
Yes, that's right. That's right, exactly. And some examples of them would be we have some circadian rhythm disorders where instead of going through 4 or 6 cycles per night, by virtue of the fact that I have what we refer to as a delayed sleep phase, which means that we are go to bed later and get up later, we may have less of these cycles throughout the course of the night. So we're shortchanging our sleep in many ways.
So these types of disturbances really reinforce the notion that to really do good clinical medicine regarding sleep disorders, you have to have a background in the underlying sleep biology and basic science.
Absolutely, absolutely. Very important in that way.
And for those persons like myself or interested viewers who want to learn more about the basic biology of sleep and of sleep disorders, can you suggest particularly useful readings or viewings?
Yes, absolutely. The Sleep Research Society, the SRS, which is a wonderful organization, they actually have a monograph on sleep biology, and it's very helpful, and it goes into all the different types of sleep neurotransmission, both wake-promoting neurotransmission and sleep-promoting neurotransmissions, and I highly recommend it. It's a wonderful text. It's
That's
relatively
great.
short duration.
Thanks for that overview of the ABCs of sleep biology. Now, moving forward, can you speak to the epidemiology of sleep disturbances in persons with autism, and how that might compare with the frequency of sleep disturbances in the general population not having autism?
Yes, absolutely. Most of the information that we have are derived from surveys and questionnaires. We have probably more information with regards to children on the spectrum than adults on the spectrum.
These are parental surveys?
Parental surveys, exactly. But it's felt that approximately about 50 to 80% of parents who have responded suggest that their children have deep-seated and pronounced sleep difficulties as opposed to children who are not on the spectrum. And these sleep difficulties are of many types. They can be, probably the most common sleep issue is difficulties in getting to sleep. But we also have difficulties in staying asleep, typical awakenings occurring in the nighttime, and difficulties in getting back to sleep.
So 50 to 80% from parental surveys represent children having very significant sleep disorders. And what is the relative comparison with the general population?
The general population in terms of having some sleep issues. Roughly, it is felt that in general pediatrics clinics, that up to 25% of the children studied had some either transient or more chronic sleep problem.
So there appeared to be a very significant enhancement of sleep difficulties in the children with autism.
Yes.
Is there much known about sleep disturbances in adults at the general sort of epidemiologic level
In
persons with autism?
Less is known in that way. We also surmise that there are similar sleep difficulties, but the epidemiology is not as well known.
Okay. Suppose a person with autism comes to you either on their own or is brought in through a parent or caregiver. What are the gamut of tools that a primary care physician has to use to dissect whether or not there may be a problem, and if so, what type of problem? And what are the tools that you, as a specialist in sleep medicine, have? And what are the strengths and limitations of each of those tools?
Sure, absolutely. Well, I think in terms of the general pediatrician, a good sleep history is extremely important, and that's true of both general pediatricians and sleep specialists. And particularly trying to determine what is the sleep problem. Is the problem my child has difficulty getting to sleep? Or does my child wake up in the middle of the night and have trouble getting back to sleep? And sometimes children have both. So the good sleep history is extremely important. If my child has difficulty getting back, how difficult is it? Is it 30 minutes to get back to sleep, or does it take hours? Or when my child wakes up at 4 in the morning or 3 in the morning, can he or she not get back to sleep at all? So a good sleep history is important. And I think sometimes having a sleep diary or a sleep log is also very important, because a lot of the children on the spectrum have what we refer to as circadian rhythm problems. And sometimes they're on a sleep diary, and they're commercially available sleep logs, which are very, very helpful. And they sort of clock the entire 24-hour cycle. And the parents are asked to sort of color in what time does their child get into bed, what time he or she gets to sleep, how many times they wake up, how hard is it for them to get back to sleep when they wake up, and what time do they wake up for good, and what time do they get out of bed for good, because sometimes those are also are different. And so, and just by observing a 2-week sleep diary or sleep log, you can tell a lot of information just by looking at it. And that's something that a general pediatrician can do easily, in addition to taking a sort of a key sleep history.
Are there questionnaires that are used in the field? And if they are they directed for children or adults or both? And are any of the questionnaires autism specific?
There actually are. They're wonderful questionnaires. And the ones that I tend to use the most are those that, as you suggested, are geared towards children on the spectrum. And so the ones that are particularly helpful, one was developed by Judith Owens, known as the Children's Sleep Habit Questionnaire, which initially was looking at children in general who are not on the spectrum, but now she has revised it for younger children who are on the spectrum, so it's particularly helpful, and it gets into great details all the different sleep issues that may be at hand.
And do clinicians administer the questionnaire? Do parents answer it by themselves and bring it into the clinician?
That's right, the latter. That's exactly right. The parents fill it out and they hand it into the clinician, and very, very helpful, very detailed. Another one now, general pediatricians are very busy, and they have to take care of a whole host of issues not related to sleep. So one of the actual tools that I like is what we refer to as the BEARS. It's a BEARS. It's an acronym, and it stands for B, bedtime problems; E, excessive daytime sleepiness; A, awakenings at night; R is regularity or duration of sleep; and S is their snoring or sleep apnea. And those are helpful because in a matter of a minute or two, you can sort of get to what the problem is. So I like that for very busy practitioners to sort of use that, and then we sort of get into some of these more detailed questionnaires.
So there's sleep questionnaires, and those are publicly available?
They are, and another good one particularly is what they call the FISH, is the Family Inventory of Sleep Habits, and that's also geared. It was put out by Beth Mallow over at Vanderbilt. It's an excellent tool, and it is specific for children on the spectrum. And it goes into great details about all the different daytime events that may lead to sleep difficulties, and also what's occurring at nighttime in terms of disturbed sleep.
So bears and fish.
Bears and fish, yes.
This is really good to know.
Bears and fish, and the children's sleep health questionnaire are also excellent.
Fantastic. And I've learned that there's a tool that can sometimes be used to assess sleep disturbances called an Actigraph.
That's right.
Can you speak to what that is and what the strengths and weaknesses of the use of that tool are, and when it might be helpful?
Yes, Actigraph is a motion monitor, and it can be placed on a limb. For example, the wrist is often used as a wristband or as a leg band, and it's basically trying to assess motion or lack of motion during the course of the nighttime. The plus is that it is easy to use, and it gives good information on motoric capacity at nighttime. It's very helpful both in the clinical sphere and in research spheres, because you can reach a lot of children otherwise might not be able to come in for an overnight sleep study, or might be fearful of doing that, or might be sensitive to the diagnostic monitoring and the electrodes that are inherent in an overnight sleep study. So I think what the relative drawback might be the fact that you're really looking at motor motor capacity or motoric ability, and it might not always signify if a child is truly asleep or the quality of sleep that they're getting. So that is probably the biggest downside.
So you're saying the person could be still, and it could be misinterpreted as being sleeping when they may in fact be awake, but just motionless.
That's right, and that's often the case. And a lot of times, children are trying to get back to sleep, and they're not moving around a lot. They're just trying to do that, and they sort of count it as being asleep when they're really not.
But it would seem to me then if the parent also does a concomitant sleep diary
Yes.
while the individual is wearing the Actigraph on their wrist or their leg, then that might partially compensate for that
That's
limitation.
True. That's true. That dual intervention would be very helpful in that way. Yeah.
Okay. And the last tool, in addition to taking a really good history and the sleep questionnaires and the Actigraph, the last tool I wanted to have you comment for us on is the Polysomnogram. What is it, and what are the strengths and limitations of that tool or that approach?
Yes, the Polysomnogram is sort of perhaps the gold standard when it becomes neurodiagnostic monitoring of sleep. Children usually come into a laboratory. It's particularly helpful for children on the spectrum to be desensitized, and because it is somewhat of a laborious procedure. But I think the advantages are clear. It's the best way to assess quality of sleep, the depths of sleep, the fragmentations of sleep. And in a way, we're looking at as a neurologist, we're looking at a lot of neural function, and it is doing, and the assessment is really a neural assessment. We're looking at brainwave activity and stages of sleep and dynamic fluctuations in sleep that are important in terms of the quality of sleep. So that truly is the gold standard. But the negatives are the fact that it is a laborious task. It is difficult to sometimes get children who have tactile sensitivities, who have anxieties about coming into a foreign environment and getting hooked up. So I think when one considers doing an overnight sleep study, one has to keep in mind that it's more laborious to do it, but it may pay off at the end. So having a desensitization period is particularly helpful for parents and child.
By that, do you mean bringing a child who may have some anxiety or apprehension to see the sleep
Absolutely.
Lab?
Absolutely. We walk the child in with the parent and have them see this is where you're going to be sleeping, and this is the sleep technologist who's going to be putting these electrodes on. You want to feel the electrode. This is what they feel like, and they actually place one on the head just so they get an idea. This is what's going to look like, and we're going to place a few more on your head, and then go over the same thing with a chest belt to check out breathing, an abdominal belt also to look at breathing, a snore microphone for those who have trouble breathing and have snoring, a finger probe to check out oxygen saturations at nighttime, an EKG, look at heart rate monitoring at nighttime, limb movements to check out for those children who move or who have excessive limb movements during the course of the nighttime. So there's a lot, it's a major assessment, but I actually find that when the effort is placed into doing that, the children often do quite well. And the notion that children won't be able to tolerate it, I think it's more a function of it's the unknown. They don't know what they're getting into. But if it's explained and they see it, a lot of times children do very well.
Will you also monitor eye movements?
And we do. We look at eye movements, that's right, because we're looking at this, trying to look at the various stages of sleep, including rapid eye movement sleep or REM sleep. So that's true. And eye movements are extremely important. We actually see lots of eye movements during wakefulness, and then a sort of what we refer to as slow rolling eye movements during drowsiness, and then a decrease in eye movements during various stages of sleep, various stages of non-REM sleep. But then, as you suggest, when we go into REM sleep, there's there's active eye movement again. So eye movements are very important in terms of the whole sleep process.
And when you do your polysomnogram, Ken, are the EEG tracings that you do the same as those that are done in your work as a epilepsy specialist in the EEG lab?
Yes, yes. Initially, the American Academy of Sleep Medicine recommends only several channels as a minimal diagnostic monitoring. But if, for example, if I have a notion that a child may be suffering from sleep-related epilepsy or sleep-activated seizures, we can actually expand the EEG.
By several channels, you mean several leads?
Several leads, I'm sorry.
Okay.
Well, several leads, several electrodes, if you will. And, but in fact, we can actually expand that to include what we refer to as a full head, meaning to say the entire EEG that you would otherwise get in an EEG lab only at nighttime. And that's particularly helpful for children who have neurologic issues that are important in sleep, sleep-related seizures, children who have abnormal arousal behaviors such as sleepwalking or night terrors, things that we refer to as things that go bump in the night, lots of different activities that occur during sleep. So very helpful in that context.
That's good. That's helpful. And many clinicians who are listening to you now will be interested in knowing if some of the medications that are commonly used in persons who have autism might interfere with your ability to do a high caliber sleep study.
Yeah, that's a great question. I think that there are some soporific agents or sedative agents that may impact on our ability to read EEG. The ones that are most often thought about in that context are the benzodiazepines. So for example, what that does is the use of benzodiazepines or barbiturates, they induce what we refer to as fast activity, usually ripples of about 18 to 20 hertz or cycles per second on the EEG. And you might say, well, why is that important? It only becomes important because it sometimes obscures underlying background rhythms. And so by having that, it may obscure the presence of spike activity or epileptiform discharges that might be important to know about, or may impact more normal brainwave functioning that we would like to see. So it sometimes obscures that process. Some other agents that are commonly used are, for example, SSRIs, antidepressants, can sometimes impact our ability to assess rapid eye movement sleep. So we often are, when we're trying to study, for example, if we suspect someone has a REM-related abnormality such as narcolepsy, we might ask them, if at all possible, to avoid taking mood medications because it can almost mimic narcoleptic sleep. And so it becomes very important to ask, are you on any important antidepressants? And if so, some of them may, by virtue of modifying REM sleep, may impact on our ability to determine whether or not rapid eye movement sleep would be otherwise present.
Mm-hmm. Do you encourage primary care physicians to contact you or your colleagues prior to a sleep consultation in case they have any questions of this type regarding medications and the potential of...
Absolutely.
Is that helpful in your practice?
I think so, because there are other issues referable to medications. For example, some medications, such as the benzodiazepines, tend to decrease the amount of this stage 3 sleep I was describing as being so restorative. So some people suggest that you may sleep with some of these medications, but it may not be deep sleep. And so that would be important also to know in terms of the stages of sleep may be affected by the presence of some of these medications.
This concludes our first session on sleep issues with persons with autism spectrum disorder, where we covered fundamental issues in sleep biology, different categories of conditions that can impact on sleep function in persons with autism, such as behavioral conditions, medical conditions, and neurological conditions, and a review of the key tools that can be used to evaluate a person with autism who has a disturbance in sleep function. Thank you very much, Ken, for helping us out to understand these issues.